It's an absolute honor and privilege to give this talk for so many reasons. In the last 40 and 50 years, this talk would have never been given, right? We go to a course like this in the 1980s, 1990s, we're not talking about this. In fact, so much has evolved in the last just 5 years in regards to this particular topic that it deserves even more special attention. And I wouldn't even be able to have the confidence to talk about this if I hadn't worked at San Francisco General, where we take the transgender patient in the emergency department very seriously. So some of the objectives of this talk today, we're going to familiarize yourself with the transgender patient and terminology and definitions. As Kevin said, having these conversations, talking about them, and treating everybody with kindness. And I'm so glad he said what he said, because at the end of the day, we want to have a good relationship with our patient. Doesn't matter who they are. But we also need to understand the barriers that transgender patients face when they attempt to seek care. And there's literature to support that. We need to recognize the special needs of transgender patients in our ED, and we also need to be aware of other considerations like the emergency medical record, rooming patients, exams, consultations, and maybe even some legal ramifications, right? Discrimination. So we're going to talk about some resources to help you do that if what I talk about in the next 28 minutes or so isn't enough. The clinical approach, well, heck, it's the standard of care to be professional. It's the standard of care to be compassionate, and it's the standard to be proactive, okay? Participate in your policy training. Know what your hospital or center offers to give you that training that you may lack. Recognize your own bias. Very important. Healthcare is a right for all people. Don't you want the best healthcare for yourself, your family member, your loved one? Always keep that in the forefront of your brain. None of these things that I just said are any different for the current practice that you have for any ED patient. But let's talk about some special considerations. What is transgender? A transgender person is someone whose gender someone whose gender identity differs from that typically associated with the sex they were assigned at birth, DNA. Now, how do you know who is transgender? You know, I called one of my very proud transgender friends, Bentley Munsell, who is in Vermont, and I said, how do you really know? So they say, well, you just ask. Why are you making it so complicated? And I said, you know what? You're right. We just ask. What's your name? What gender were you born with, male or female? Be direct. Do you identify as male or female? What would you like me to call you? Please tell me about your medical history. Tell me about your body. Tell me what is important. That includes surgeries, hormones, medications, trauma, mental health diagnoses, and anything else that is important that will help me take better care of you today. So we know, as we said, this is evolving. There are spectrums. There's things that, even after this talk, you still find confusing. But talk about it more. Discuss it more. Read more. So, of course, we know gender, DNA, male or female. And we're going to talk about intersexuality or intersex people who actually may have organs of both male and female. But bear with me while we just talk about gender being male or female. Gender identity is something different. They might be born a male, but identify as female. And this is chromosomal. So I might identify as a female, but again, my chromosomes were born a male. Might be female, but identify as a male. Might be non-binary, no specific identification. This is gender identity, okay? Sexual orientation, I really don't care about any of that. It's completely irrelevant until it is important, right? So this might be important for abdominal pain and pregnancy, sexual assault, talking about STIs or preventative care. That might be gender specific. The term hermaphroditism is actually extremely offensive. If you really look at the root of the word and where it originated from, it's pretty offensive. We use the term intersexuality or intersex, which is about almost 2% of our population. That's defined as a person having external or internal sexual organs that are not as clearly male or female. They have chromosomal differences. They have ambiguous genitalia. In the 1950s, surgeons who found these patients performed unnecessary and dangerous surgeries on infants because they were not normal. I also don't like that term normal. It shouldn't be, it's something that we just shouldn't be saying normal. What is normal anyway? Maybe what's expected? What's an expected heart rate? You know, we have parameters. What's an expected thing to find on that particular exam? Expected. I try to remove the word normal from my entire vocabulary. And in regards to these surgical procedures, they were irreversible. They caused scarring, ethical considerations and pain, sterilization, shame, secrecy, mental health damage. The APA, the American Psychiatric Association, and the DSM-5 recognizes some of these gender dysphoric personality and or behaviors as a diagnosis because it's important to identify what it is and be able to help patients who may be experiencing this. And I'm going to talk about why it can be very detrimental for transgender patients to be seen in a healthcare facility for their mental health based on the literature. Family and societal rejection of gender identity are some of the strongest predictors of mental health difficulties among people who are transgender. Wow, they're going to us for help, and they feel worse. Some other things I want you to keep in mind. There is ambiguous genitalia. There's micropenis, there's no vaginal opening, maybe both ovaries and testicular tissue. There's lots of things. That doesn't necessarily mean that they identify as a transgender person. People might have excessive facial hair, body hair, deep voice, high voice, abnormal breast development, all kinds of things. Again, they can have those things and not be transgender. So again, just ask the question. That's why it brings me to this next slide, intention versus impact. How many times have we unknowingly insulted someone? In fact, you've probably insulted a lot of people in your life and don't even know it. Hell, I could have insulted someone in here in the last 10 minutes, and I'll never know unless you tell me. So we need to understand that really we don't intend to be hurtful. I mean, I certainly don't, but we all make mistakes. The reality is we make mistakes and missteps that may negatively impact the patient and cause harm. This leads to micro-traumas, microaggressions, fragmented care, which then leads to health anxiety, difficulty navigating the system, distrust, and then they don't seek care at all, which leads to more complications. I want to focus specifically on the adult transgender patient because they are an at-risk population. When you hear this phrase, at-risk population, you think to yourself, well, how do I know? Well, having taken a really deep dive into the understanding of the LGBTQ plus community in the last couple of years in San Francisco and in the literature, it's really sad what I've been reading. It's very upsetting to me, and I want it to change, and I want it to start with all of you too. They're an at-risk health population because they have poor health outcomes and fear of the healthcare setting. And that's because of some of us. Not necessarily somebody in this room, but because somebody did that to them. They have trans-specific negative care. Because they are a certain way, they got worse care. Not acceptable to me. This is because there's just clinician unfamiliarity, and then unwanted exams, inappropriate questioning or not questioning, repeat questioning, not enough questioning. So hopefully I can help you try to break this down to very straightforward questioning and patient care that you've already been doing. Trans people are up to 3 times more likely than the general population to be diagnosed with a mental health disorder, almost 50%, and substance abuse. So looking at the literature, looking at this first study, it's a 2014 study in the Annals of Emergency Medicine. Reported ED avoidance, use and experience of transgender persons in Ontario, Canadian study. And the results of the respondents here. More than half of the patients said that they had a negative experience. Didn't even matter what they were there for. They weren't even there for a trans problem. They were there because they had a sore throat, or maybe they had abdominal pain. 32% had insulting language said to them. And 10%, 10% refused care for being transgender. Another study, transgender and gender non-binary patient experiences in the emergency department study in the Journal of Emergency Medicine. Significant differences between trans and non-trans patients because, you know what? Hospitals lacked training. They weren't owning this. They weren't saying, hey, this is a problem. There were no protocols. There were no policies. But at the end of the day, it's another patient. Yes, there are some special considerations we're going to get to at the end, but they're another patient. They're another human being. So what did we do? Well, we decided to take action. Let's do a systemic review and look at quality assessment and the synthesis of guidelines for ED care of transgender and gender diverse people. What are the recommendations to improve this care? How can we do better? So we created a lot of different materials to help us do better and recognize our shortcomings. And realize there are a lot of opportunities to build community-led research programs and create centers of excellence. What exactly is a center of excellence? I'll get to that in just a moment. But before I do that, I just want to remind you of the law. Discrimination is unethical, it's wrong, it's illegal. And federal law prohibits sex discrimination. That's Title VII, Title IX, and Equal Protection Clause. That prohibits discrimination against transgender people, whether based on sexual stereotypes, gender identity, or gender transition. Now, the Joint Commission supports non-discrimination and the enforcement of their policies, and that's why we have a patient bill of rights, and also confidentiality. So let's move on to a patient that comes in that you know is transgender or you've identified as transgender. Are these workups any different for the list that I have here? Is ankle pain different? Is headache different? Is dehydration different? Is abdominal pain different? Chest pain different? Back pain? Sexual assault? Yeah, I can pick a couple on this list that are going to be a little bit different. Let's say that you have a gender-born male who has transitioned to be a female. And you're thinking, well, this patient is here for sexual assault, and I need to do some testing. Do I need to get a pregnancy test? No, I don't. And it's okay to say, you know what, I don't need this test based on the genetics of this patient. That's when that would come to. Also, abdominal pain in a female patient who has transitioned to be a male. Do they still have their ovaries? And are they pregnant? These are questions that we need to ask. We know that risk factors are different for acute MI in male versus women. Presentation is different. So as you start to think about this, it is a little bit different, but it's still the same. You're still chasing your workup and diagnosis and treatment. You're just taking on a couple specific considerations. So how do you assess that transgender patient? Well, first you discuss your plan. You talk about the details. You recognize any special needs in the beginning. And like I said, it's not much different than your usual approach, except a few additional questions. So let's say you have a transgender male who was born female. Explain, this is why I would like to get a pelvic exam. Every time I do a pelvic exam, I say, hey, I'm going to do a pelvic exam. This is what it looks like. This is what I'm going to do. And this is how it's going to feel. And I just want to let you know that I'm going to talk you through it. So again, my practice really hasn't changed, but I might take an extra minute to explain why I'm doing this. Different differentials, as I mentioned, might be present. We already discussed that. Allowing a support person. They actually looked at literature, not just for transgender patients, but for all people. Having a family member in the room or a support person is very helpful. But in some cases, you may need to excuse them. Maybe a family member or friend doesn't need to know the intimate details of this patient's history. Maybe they're too uncomfortable to say, I need you to leave. If you're reading that situation correctly, I think it's fine to say, I'd like to excuse everyone from the room right now except the patient. And then you can ask the patient, hey, listen, do you want me to bring that person back in? And they'll tell you. Remember, if there's going to be a SANE exam or caseworker or something that involves invasive exploration or treatment, please avoid gaps in care. When a patient comes in of any sexual assault experience, I really don't ask them a lot of questions if I'm in triage or if I'm not going to be the main person taking care of them. I get very brief, and I go, this is not because I don't care, it's actually because I care. So I'm going to put you in a private area, I'm going to allow you to talk to someone and just that one person. But I'm available if you would like to talk to me now. I also like signing out my patients with another clinician at the bedside. I think that's really important too, regardless of transgender patients, just in general. I think it's very helpful. So let's talk about some of those special considerations. And some of the ones I really want to highlight on are really the obvious questions, like, What about surgeries, augmentations, prosthetics? What do I do when these come in? Like, how do I handle these particular situations? I actually asked a lot of transgender patients and personal friends of mine. I said, I've heard this term organ inventory being thrown around. It seems kind of offensive. Oh, no. This is actually, tell me about your body. Yeah, I would like to take an organ inventory. Can you tell me about your body? It's a nice approach. Explain why it's important and relevant to care. And then ask about male to female. Did you have breast augmentation? Have you had anything removed? Can you tell me about any other implants? And when that happens, you're treating infection the same way you treat infection. You're treating possible sepsis the same way you treat sepsis. Regardless of what surgery they have, be very clear what it was and who was the clinician that did it. Contact them if you possibly can, because a lot of these procedures are still in experimental phases. Some non-surgical body modifications that you might see in male to female might be breast enhancements from stuffing, and I've actually seen quite really serious fungal infections from that and irritation. Tucking can cause scrotal trauma or infection or even urinary trauma, so I might be searching for some other things, prostatitis or cystitis. If patients are on estrogen, that might put them more at risk for blood clots, or androgen blockers, blocks testosterone, and other diuretics. These can cause electrolyte imbalances. I have to tell you, I had a patient recently that transitioned from male to female and was taking a lot of estrogen. You know who I called? Diane. Not on shift. We talked about the case anonymously later. She had no idea when I had the patient, completely anonymous. I said, does my suspicion need to go up higher? I told her the whole case. In this patient with estrogen, I mean, how do I make that decision? Is it any different? No, it's estrogen. I mean, you're still evaluating for blood clots, right? I go, yeah. Well, and I did, of course. And so sometimes just to talk some of these cases out, doesn't matter what the case is, can be helpful. Also, there could be the use of binders, which can cause really significant breathing restrictions. I had a patient that wore a binder, and they said, look, I'm having really bad chest pain. And I said, well, let me take a look at your binder. And of course, I was digging into their chest. I said, listen, we got to loosen this up a bit. But it was very important to the patient that they wore it, and I understood. So we actually came up with a better plan to put some Curlex around, and we did get to loosen it a little bit. And I had the patient return the next day. Chest pain got better. So sometimes just a little intervention and support. I mean, it would be really rude to say, you can't wear that anymore, okay? Because that's how that person, that's what they're doing right now, okay? They just want to live their life, just like everybody else. So laboratory testing, also important. My friend Bentley told me that sometimes the lab has this gender mismatch thing. We don't experience it at the general, but I know that other labs do, where maybe the chart is confusing, where like you're not quite sure what the genetic gender is, but the gender identity might be something different. In which case the lab will be like, I'm not processing an HCG, this is a guy, you know? And you're like, no. Like, easy with the terms. You know, people are still not using the right terms. It's just rude, because it's not hard to do. So then you explain, before you even send that HCG or the penile swab or the vaginal swab, those tests, maybe just give a heads up to the lab. That's one solution. Same thing with ultrasound, CT, and X-ray. Walk your little feet over there and talk to them and give them a heads up about what's happening privately. Have patients self-swab whenever possible. You know, we've been doing this, and it's great. And then, of course, educate the staff on specimen labeling. Let's talk a little bit about the EMR, which I find very important, because now we're getting into medical legal, right? So patients, they can all see their charts. So what's important in Epic? I don't know how any other particular health system is doing it, but I think that this particular record does a good job, because you can put in the sex assigned at birth, the gender, and then you can also put in gender identity, as well as sexual orientation and preferred names. So I can tell you, it's horrific when you walk out into the waiting room and you're yelling a person's name that they do not go by, and it's trauma for them. And all you had to do was look to see that this patient prefers to be called this name, just their name. I certainly have gotten people's names wrong. Just on this conference I have. On panel, I called somebody by the wrong name, and I was mortified. It really upset me. So imagine what it feels like to that person to constantly be called the wrong name. Just pay attention. Epic also has a built-in that allows you to put in organs present or removed and hormone enhancement. And then again, training the staff to use these build-ins is very important. Doesn't take a lot of time. You can teach anybody this stuff. Registration, records, and insurance, all those interactions should be very private. I really don't like registration roaming around in triage being like, you know, so-and-so, but telling all their names. I'm like, oh my God, can't you, like you're gonna get the billing. Can you just wait like a little bit? Put them in a private area. So the interesting thing is that the AMA and the APA recognize sex reassignment surgeries, okay, and hormone therapy for gender dysphoria, which is why it is a diagnosis in the DSM-5. So insurance companies may still be restrictive. There might be denial of claims, but more and more of them are being allowed. State governments have eliminated trans-related discrimination, as I mentioned, in health insurance coverage. Not all the states, but we're getting there. CalPERS, which is the big California insurance, trans-inclusive care. Pretty cool. CMS, they've even caught up. They're using appropriate coding. So there's a specific code, if you're into this, for ambiguous gender categories. So that way when they get sent a bill for a lab or something that doesn't, it's a mismatch in some way, CMS is able to look at this and say, oh, okay, this falls under these ambiguous gender category. There's another really great packet. It's about, I'd say less than 20 pages, this transgender hospital policy approach that's available. I can direct you to a website that helps you kind of work on all the things we just talked about in your department. So recommending best practice here is to room patients based on their self-identified gender, right? So if this person is a woman identifying as a female, she will be partnered with another female. Now, the gender identity at birth may have been male, but she would like to be in a room with another female. That's a conversation with the patient. If it causes issues or concerns, this packet goes into all of that. Place the patient in a private room. If a private room is not available, well, we have a lot of extra steps for that. Hopefully you don't get there, but this is not like a difficult situation. It really isn't. Just take a stepwise approach. Also, all patients of the hospital may use the restroom which match their gender identity without harassment. Access to hormone therapy, very important that this is continued and uninterrupted for a variety of reasons. You really don't want to stop anyone's hormone therapy because it's just detrimental to the patient and it's also detrimental to you. It's going to be more difficult to take care of that patient. If a healthcare provider is unfamiliar with this aspect of care, then they should definitely consult a specialist or at least the patient's primary care or surgeon, whoever they've been working with, because abruptly stopping them, like I said, can cause some serious consequences. Now, I debated discussing any of this in this talk because it's very sensitive. And I want to, just like Diane, the post-Dobbs era, I'm just going to present to you the information in which I have, and then I want you to check with your state guidelines. I have two very dear friends who have children who are very young, 8 and 12. And both of those children are transgender at a very young age. I've talked to them. I've listened to the stories from the parents and what they go through. And it's a very difficult life for them. But they find a lot of relief when they find a center for excellence, like I'm going to talk about at the end here, of people getting together to really help kids. And although it's a very controversial topic, there are a lot of laws that just prevent us from doing anything to kids who want gender-affirming treatments, or GATs, or hormones, or even reversible treatments. So in Idaho, and is there anyone here from Idaho? I felt like there was one person. A doctor providing gender-affirming care, or GAC, to a minor could face up to 10 years in prison. So let's say that patient I was taking care of was wearing a binder, and they came in for chest pain, and they were 17 years old. Still a peds patient. I lived in Idaho, and I continued to let them use their binder. I could go to jail for that. I don't like that. I don't like that at all. In Florida, parents who allow minors to have any gender-altering surgeries or care, just care in general, the C, can lose custody of their child. Say they're incompetent, that they're not good parents. Just putting that out there. Pediatric transgender patient also has an increasing rate of suicide, depression, anxiety. And these are kids that might just want some gender-affirming things like clothes or a name. Like they're not, I want a penis or I want a vagina. These are just kids that just want to, have something affirming to make themselves feel more itself in their body. So sometimes we do give treatments that are difficult to reverse, but if we don't give treatments, that can interfere with their everyday life, make school harder, socializing, and their emotional health is at stake. So the American Medical Association say that decisions about medical care belong within the sanctity of the patient-physician relationship or clinician, not the state they live in. But the laws and the guidelines are constantly being updated and changing, so you need to be aware of them. Check on what's illegal in your state and continually check these trusted resources, which I'm going to give you a few more. This is just some statistics showing you there's a policy tracker. It's an independent source for health policy research, the KFF. And basically what they looked at were states that have enacted laws or policy limiting the youth's access to GACs. It's about half the states. And about 38% of trans youth aged 13 to 17 live in a state with laws that limit their access to gender-affirming care of any kind. You can see why that would prevent them from getting medical care. 17 states are facing lawsuits right now, probably more, probably 5 more since we started this course. This number changes frequently. And again, 22 states impose professional or legal penalties on healthcare practitioners for simply providing minors with GAC. These are some of the states that have enacted the laws, just putting it, I like what Ken had made where, he made some graphs with no numbers at all. I think it's very impactful to see something just either black or white or green or yellow and look at the difference and measure it that way than just sometimes looking at the actual written number. Just ending on a few very important things. Rape, assault, and abuse, we've touched on it a little bit. I certainly always ask patients if they have involved the police or would like me to call. That's one of my first questions. And then also asking about interpersonal violence and letting them know this is a safe space. Okay, this is a safe space where we can talk. Some of the other organizational references that I would like to suggest to you, where you can get some guidelines, policies, procedures, and statements. The American Academy of Pediatrics has a very clear one. The American College of Emergency Physicians, ACEP, has one. As I mentioned, a few things from the AMA and the American Psychological Association, the APA. So stay up to date. So onto this center of excellence thing. Like, what is a center of excellence? Sometimes I feel like my house is a center of excellence. Like, I'm a really good parent. I make decent money. Like, I put food on the table. This is a center of excellence. Everybody's coming together and we're making things work. I researched all the food delivery places. HelloFresh by far was the best one. I'm really feeling that you all could have a center of excellence. And it's kind of an interesting definition. It's really a place where the community is engaged, as well as clinicians, physicians, and other providers, to provide care to patients in a safe and respectful environment, integrating research, continuing education, and care of any patient or person. And truly, to be a center of excellence, all you have to do is be aware and figure out what you don't know. And that's a hard thing to do. That was always the hardest thing when I first started practicing. I knew the things I knew, but I didn't always know the things I didn't know. So work on some care pathways, look at some toolkits, look at some resources. UCSF has a wonderful Center for Excellence for Trans Health, and they have a lot of sample forms, including consent templates, appropriate wording, and helpful documents for both adults and pediatrics. These are those actually 3 things I would suggest for resources. The Human Rights Campaign was the Transgender Patient Hospital Policies packet that I was talking about. The WPATH, which is the World Professional Association for Transgender Health, they're on version 8, which is really cool. That means they're constantly updating this. And then the Fenway Institute is another LGBTQ health education site that you can go to help you understand and treat patients with care. So ending with a sample conversation. Hi, my name is Martha Roberts, and I'm the nurse practitioner taking care of you today. We ask all patients these specific questions. Would you tell me your name and your pronouns? Okay, I read the notes on what's going on, but I'd like to make sure I have the important parts of your health complaint correct and just ask you a few more questions. My goal is to help you with this today. I'm going to do my best to ensure that I'm a caring advocate for you. I noticed that you were born a female and are in the process, or have you already transitioned to a male? Can you tell me a little bit more about your journey and your health history? I'd like to know about your body. Could you tell me if you've had any surgeries specific to your transition? Very important. I just want to ask you, do you have your ovaries and do you still get periods? I see in addition you want STI testing today. Well, I can take the swabs for you if you like and do a pelvic exam if you feel comfortable with that plan. If not, I can offer you some other options. Would you like a chaperone during your exam? Reminders. Same slide, repeat it again. Be professional. Be compassionate. Be proactive and participate in policy training. Appreciate the differences amongst all people and recognize your own health bias. Healthcare is a right for all people, and none of these things are any different for your current practice for any AD patient. But if there are some special considerations for a population, I'd adhere to them and try to do your best. Thank you.